am Dr. Avinash S S, one of the mentor at StudyMEDIC StudyMRCOG group. In today's video on RRR series is on Biostatistics for MRCOG part 2. And we shall be discussing today 15 EMQs and 15 single best answers with options and explanations. Now the EMQs: choose the most appropriate study design for the following research questions. Choose the answers which best matches each of the following questions. Each option may be used once, more than once, or not at all. So this topic is based on the study design. So the options are case control, cohort study, RCT, that is randomized control study, cross-sectional analytical study, longitudinally descriptive studies, surveys, systematic reviews, and meta-analysis. These are some of the options. Now we'll see the questions and then the options, answers, and then we'll discuss each options and why it is the best later. Now the question is, to measure the prevalence of a disease, which is the best suitable study design? Next, to measure the incidence of a disease, which is the best study design? To assess adverse drug effects, which is the best study design? To assess diagnostic accuracy tests, which is the best study design? And which is the best study design to assess effect of intervention? Excuse me. To find the overall effect of a drug using several RCT. To compare HbA1c in smokers and non-smoker pregnant women. To study a disease with a long latent period. To find etiology of a disease. And to study multiple outcomes of a rare exposure. Now we'll see the answers and then we'll discuss why they are the answers. To measure the prevalence of a disease, it is the descriptive cross-sectional study design, that is survey. To measure the incidence of a disease, it is the cohort study design. To assess the drug effects, again, cohort study designs are the best ones. To assess diagnostic accuracy tests, the cross-sectional, analytical cross-sectional study designs. There are two cross-sectional study designs: descriptive cross-sectional study designs, and that is a survey, and analytical cross-sectional study designs with control. To assess effect of intervention, that is RCT. To find out the overall effect of a drug using several RCTs, we use meta-analysis. To compare HbA1c in smokers and non-smoker pregnant women, we use cross-sectional study design, analytical study. To study a disease with long latent period, case control study design. To find the etiology of a disease, cohort study design. And to study multiple outcomes of a rare exposure, we use case control study design. Now we'll see one by one, and then I will come back to the options. So study designs usually are divided into epidemiologically interventional study designs and observational study designs. Interventional study designs are also called as experimental study designs. And here there is an intervention which changes the course of the outcome, either in the form of treatment, counseling, training, or stopping of all this, etc. The observational study design do not have any interventions. They do not change the course of the outcome. The interventional study designs are further called as the experimental study designs based on whether the subjects are chosen by randomization or not. They are classified into randomized study designs, where participants are allotted after randomizing so that there is less bias, and non-randomized, where the participants are allotted based on the convenience, called as the quasi-experimental study design. Now the observational study designs, which are non-interventional study designs, are classified into analytical, those with control, and descriptive study designs without control. The analytical observational study designs with control are classified into examples: cross-sectional study design with control, case control study design, and cohort study design, which is both prospective and retrospective study designs. Descriptive observational study designs are without control, and for example, they are cross-sectional surveys of small population, census of large population, and case history or series. They are the descriptive observation study designs. Now, to summarize, interventional and non-interventional study designs. Interventional are RCTs, quasi-experimental. Non-interventional are analytical, that is case control, prospective cohort, and cross-sectional with control. And the descriptive are case control and case reports and the surveys and census. Now, survey is a descriptive observational study design without control. Here, within a single point in time, we take both the details about the sample, that is the details about both the exposure and the outcome at a single point in time. Okay. So, this, when we take a single point in time, we get what is called as the cross-sectional study designs, single cross-sectional study designs. So, there is analytical cross-sectional study design. The difference here is it has a control group also. Okay, it has a sample control group also here. That is, and there is a sample versus control which you can compare. It is both details about the exposure and both the exposure and the outcome details are collected here of both the sample and the control. Now, these are used to check the prevalence of the outcome. That is, prevalence of symptomatic pelvic organ prolapse, often among women of more than 40 years. Prevalence of traits, that is alcohol intake and smoking habits in men and women. To check the attitudes and knowledge among patients, that is majority of both women and men undergoing IVF treatment do in fact prefer to have twins or not. Attitudes and knowledge among health personnel, that is knowledge of fertility among OBG residents, etc. So cross-sectional studies are also used for validation studies for comparing, that is analytical cross-sectional study designs, as I discussed, like different measurement instruments, comparison of register-based data with information from medical records. It is also used to assess the diagnostic accuracy studies, wherein the test is positive and disease is also positive. Test is negative, disease is also negative. What is the sensitivity? What is the specificity in those patients? To do that, we do cross-sectional study design. There are also reliability study designs, and to check the association between risk and outcome, also we can use that. And there are analytical cross-sectional study design means, for example, weekly drinking of alcohol in those with binge drinking before versus after the recognition of pregnancy. To where we have two groups which we can use to compare. But at a similar point in time, we are taking the details about both the study groups here. Before, that is before versus after recognition of pregnancy. Singular point in time, we take the history of everything and compare that. So the analytical cross-sectional study design. There are advantages is it is cheap, faster, easy to conduct. Multiple variables can be analyzed. Disadvantage is it cannot look at the changes over time. It cannot conclude the causality. There is always a selection bias. That is, investigator can choose to select the cases which may be favorable to this hypothesis. And there may be information bias also. They may fail to recall, and there may be detection bias also because of the inability to find the risk factor. And there are confounders. These are the risk factors. So case control study design are different. Here, it is good for rare disease and disease with long induction and latent period, because a rare disease can be screened for, and with using the diagnostic criteria, we can select those with the rare diseases in a particular locality. And based on this, we can also select age and gender and other matched controls with similar to the cases, except that they don't have the rare disease. And then we match them. We ask the details about the exposure, whether they were exposed or not exposed. Similarly, we ask the same details about the exposure to the controls. So when we ask that, we ask the odds of cases in exposed and odds of control cases odds of exposure in cases and odds of exposure in controls. And then we divide it to find out the odds ratio. So you can see a rare disease like a cancer or a rare disease like bladder carcinoma can be chosen, in which we may ask them the history of, let us say, exposure to certain, or not one, but multiple exposures, whether they were exposed or not. And then we can find out the odds. Okay. So because it is not having any follow-up, it is not having, it cannot calculate the incidence, but it is very cheaper, easy to conduct. Low sample size can be used. Multiple risk factors can be, history can be taken. Rapidly it gives the results. Useful for the rare, that is the rare diseases. Because if we have to follow these rare diseases to develop, it may take a lot of time. So based on that, we choose the rare disease. Now, the other type of studies. What are the advantages and disadvantages of these diseases, case controls? It cannot look at changes over time. It cannot conclude the causality because there is no follow-up. It cannot calculate the incidence because of the same reason. And it is not useful for rare exposure because these cases may never be exposed to that rare exposure. So these are the disadvantages of the case control study designs. There is, of course, again, similar to cross-sectional, there is a selection bias of including the cases, while including the cases. And there may be very good, very high chance of recall bias. The cases are more prone to recall the history of exposure compared to the controls. Now, the case control study designs, it is the history of, for example, you can see multiple sclerosis, a rare disease, and history of sinusitis can be elicited and compared with the controls. Similarly, tuberculosis and history of taking BCG can be elicited, and the odds can be calculated of developing tuberculosis who are BCG vaccinated and not vaccinated. Now, prospective cohort study designs from the present time in a particular population, we may wait for the population to be exposed, or we can select the already who are exposed. Especially suitable is to select this type of study design to examine the effect of a rare exposure. So when we select this exposed, then we select those who are not exposed from the similar locality. Then we follow them up to see whether they develop the outcome or not develop the outcome. Not just one, but multiple outcomes can be followed up. Similarly, we follow the who are not exposed also. Then we calculate the incidence of development of the disease in exposed and development of the disease in not exposed. And then we calculate the relative risk. So there is a follow-up here. So it is good to calculate the incidence and establish the etiology and the causal nature of the disease. So that is the usefulness of the prospective cohort study design. Multiple outcomes can be assessed. Then the retrospective cohort study design, from the present time, we go back in time and take the history of or identify those who are exposed using the medical case registries. Then we select the similar from the medical case registries, those who are not exposed. Through the medical case registries itself, we follow them through the time to see if there are any record of them developing an outcome or not. Then we calculate the incidence of the development of the disease in those who are exposed and not exposed and calculate the relative risk till the present time. That's why it is called as a retrospective cohort study design. There are advantages of cohort study designs. It is good for study of rare exposures. Multiple outcomes can be studied. Incidence and relative risk can be calculated. The temporality and causality can be established. It can also be used to investigate common exposures. But the disadvantages is it is not useful for a rare outcome. You may never get, if it is the disease takes itself is rare to develop. And there may be loss to follow up differentially in cases as well as the controls, introducing the type of bias. It is very time consuming, logistically difficult, and relatively expensive. There is always a chance of selection bias and a little chance on recall bias. Now, the prospective cohort study examples is those who are exposed to the toxic chemical and develop cancer. Incidence of cancer in those who are exposed to the toxic chemicals and those who are not exposed is an example. Similarly, those who developed anomaly, in those who are exposed to thalidomide and not exposed, what is the incidence and what is the risk of development of an anomaly in those who are thalidomide exposed? It is also one of the retrospective cohort study design. We go back and see in the register who are exposed and see whether they had developed anomalies. Then the RCTs are randomized control trials. From the population, we recruit them based on certain criteria and we randomize them into intervention and non-interventional arm to minimize the bias and the effect of the confounders. Random allotment is preferred. Then there is the allocation concealment in which the program manager who will be subscribing them to the intervention non-intervention arm will not know whether the person who is coming now or next will it be going to the intervention or non-intervention arm, because this allocation of these subjects who are already randomized is again concealed in a sealed envelope, for example. Then the measurement of the effect of intervention is blinded. Either the patient themselves may not be knowing whether they are having an intervention or non-intervention. For example, drug and placebo, which is similar to the drug, and the investigator also may not be knowing whose data he is measuring. Then it is double blinded. If both know whether who is in the intervention and who is not in the intervention, it is an open-ended type of RCT program, we call it as. Then we follow them up. After we follow them up, we take them whether they develop the outcome or not, similar to the cohort, and then we calculate the experimental event rate of development of outcome in the intervention compared to the control event rate of development of outcome in the non-intervention arm to calculate the relative risk. Okay, then we calculate the relative risk or the effect estimate based on intention to treat. That means all those who were recruited are considered to be completing the study, and then based on that we calculate the relative risk. If we remove those who are lost to follow up for various reasons and then calculate the relative risk, then it is called as per patient protocol analysis. Then we can do subgroup analysis based on those who develop the disease. We may subgroup them into those who are smokers or non-smokers, those who are chronic alcoholics or non-alcoholics, and then do the subgroup analysis. Also, this subgroup analysis can be the effect of one confounder on the other can be adjusted by using the adjusted logistic regression. The advantages of RCT is good for study of effect of intervention. It is because it is randomized and allocation concealed, the least chance of selection bias is there, and it minimizes the confounding of the known as well as the unknown factors. Then there is a blinding, which will minimizes the information and detection bias. Disadvantages is it is not useful for rare outcome. It may never have developed. Differential loss to follow-up may introduce bias. Very time-consuming, logistically difficult, and relatively expensive. There may be selection bias and information bias, which can still be there. And of course, confounding if randomization is not properly done. The limitation is if there is a small sample size and the study is of short duration, it may be very, very less powered. Okay. For example, to detect differences between comparators in uncommon or long-term harms, to detect differences on several measures of effectiveness, when you take the small sample size and short duration, it may be underpowered. If you are studying a rare disease and a very small population of interest is available, enrollment may be very challenging. Sometimes it may be unethical to continue the study when we know the drug of intervention is actually beneficial, and we are limiting those who are not taking the drug from these beneficial effects. There may be infeasibility, it is high resource intensive, and there may be narrow eligibility criteria, so the participants may be not be selected. If it is tightly controlled intervention means it may not be generalizable. Okay, so these are the limitations of the RCT. Now, several such RCTs or case controls or cohort study designs can be collected and reviewed. So what is systematic review? We identify these study designs we appraise these study designs, either case control, cohort, cross-sectional, or RCTs. Then we synthesize all the empirical evidence that meets a pre-specified eligibility criteria to answer a specific research question. For example, if statin decreases the risk of cardiovascular disease if given prophylactically, then we select all those who are undergone this RCT for statins. Then we appraise all these RCTs, then synthesize all the empirical evidence, whether these are, what do these studies tell us about. Of course, with minimal bias. So this is systematic review. Now, if these results of all these individual studies are combined to produce an overall, what is the effect of this drug on the incidence of cardiovascular disease, for example, this is usually called a meta-analysis. And it is usually represented using a forest plot. Okay. So all meta-analysis, they should be a systematic review. Okay. Not all systematic review can undergo meta-analysis. Some of the systematics can further be analyzed to find out the overall effect of all the studies, and that is called as meta-analysis. Now we will see the questions and see the answers. To measure the prevalence of the disease, to measure the incidence, etc. So what is the measure to prevalence of the disease? It is the cross-sectional, observational, without the descriptive study design, without control, survey. To measure the incidence, cohort study. To assess the drug effects, diagnostic accuracy studies. Effect of a drug in already to assess the adverse drug effects, cohort study designs are used. Because we need to follow the drug to see the effect. To assess the diagnostic accuracy tests, cross-sectional selection of both this with the treatment and without treatment, and true positive, true negative to be find. Cross-sectional analytical study design with comparison should be used. To assess the effect of intervention, RCT. To find the overall effect of a drug using several RCTs, where the overall effect of the drug is found. It is meta-analysis, as we discussed. To compare HbA1c in smokers and non-smokers in pregnant women, we have two groups who are selected, and the data on both the effect as well as the risk factor is collected and compared. It is the analytical cross-sectional study design. To study a disease with long latent period, means it takes a lot of time to develop. We may as well select those who are already having the case and do the case control study and ask the history of exposure to find the odds of disease in those exposed and unexposed. To find the etiology of a disease, we need to follow them up to establish the temporality, and the best is the prospective cohort study design. And when we have to study multiple outcomes of a rare exposure, again, the rare exposure, if it is selected and then the follow-up to see not one outcome but multiple outcome. For example, those who are exposed to a radiological phenomena, who if they develop skin cancer or testicular cancer or brain tumor, etc. This is a type of prospective case control study. So to study multiple outcomes of a rare exposure, it is not actually a case control study. It is the cohort study design, because the rare exposure, we need to follow them up and study the multiple outcome. And this is the actually not case control, but cohort study design again. For case control study design, we can study the multiple exposures of a rare disease, as we have discussed earlier. Okay. So please take a note of it. Now, the another question is, a group of doctors want to review the literature about Mirena used in HMB. So is this audit, cohort study, RCT, or meta-analysis, or systematic review? So you can see they just want to review. They are not further analyzing the use. Taking collectively all the studies, and they are not further analyzing the overall effect of the Mirena use in HMB. So that means it is systematic review, as I have discussed. So a study is carried out to see the effectiveness of sutures and technique used for third and fourth degree peroneal tears by a senior consultant over the last 2 years. The results are compared against RCOG basic standards. So is it an audit or cohort or randomized control study or meta-analysis or systematic review? So you can see the results are actually compared against a basic standards. So here they are doing an audit. Okay. So they are, the intention is to see the effectiveness of the sutures, how they are practiced or not. Then they do go and measure the effectiveness and see over the last 2 years and compare against the RCOG basic standards whether it is effective or not. So it is an audit. You can see the audit is having 3 stages: planning, audit, and action stages. The planning audit is selecting the topic. Here, the selecting the topic is to see the effectiveness of sutures and techniques used for 3rd and 4th degree perineal tears by a senior consultant, and agree standards of best practice, RCOG guidelines they can take up. Define the methodology, who are going to audit, how many are going to audit, when they are going to audit, and what they are going to audit. Then take the pilot and data collection, after which you do the data analysis and see whether it is really effective or not. And then make your recommendation, implement the change, and then re-audit if there is a improvement, okay, based on your recommendation. Based on the different types of sutures and technique employed, you can recommend a particular type of sutures and technique, okay, for a 4th degree perineal care. So this is the type of audit when we take, compare it with against a already known checklist of standards. Now, for example, it is another question on the type of errors. So here mifepristone also helps to induce labor, but not much evidence. Hence, null hypothesis is accepted even when not true. That means mifepristone, which is used to induce the labor, there is not much evidence. Hence, null hypothesis is accepted even not true. That means null hypothesis is not true. Then also it is accepted. So what it is? Is it type 1 error, type 2 error, power, confidence, or a semantic or literature type of error? The answer is it's type 2 error. Let us see what it is. So here null hypothesis is not true, even when not true. Okay, that means null hypothesis is false. Then what we should do? We should reject the null hypothesis and conclude that mifepristone is effective. Okay, so here instead of rejecting the null hypothesis, since null hypothesis is false, we have to reject the null hypothesis to give a very true positive finding. If the null hypothesis is false and we fail to reject or accept it, then what we are doing is we are concluding null hypothesis is correct and concluding that there is no difference or there is no effect. We are giving a false negative finding. And this false negative finding is called as the type 2 error, also called as the beta error. The acceptable beta error should be less than 20%. Okay. So mifepristone also helps to induce labor. So this we should have proved it here, but not much evidence. So okay, not much evidence in our study. Hence, null hypothesis accepted even when not true. Null hypothesis states mifepristone does not help to induce labor. Okay, so we know it is not true. We should have rejected it, but we have not rejected it and concluded there is no effect of mifepristone on induction of the labor. So we are giving false negative report here. It is type 2 error. Now, similarly, another question, related question, null hypothesis not rejected when false. That means, again, null hypothesis not rejected means what? We failed, we accept it. Okay, in other words, we accept it. When false, we should have rejected it. It is the same answer. It is type 2 error. So again, null hypothesis is not rejected when false. Both are same. You can see fail to reject. Null hypothesis false. Here we fail to reject. Not rejected. Or if we can tell it, accept. It is not correct. Fail to reject is not equivalent to accept. So it is again type 2 error. Then another related question is, mifepristone also helps to induce labor since there was enough evidence. Hence, null hypothesis rejected when false. Correctly, we are rejecting the null hypothesis. Null hypothesis here says mifepristone does not help. There is no effect of mifepristone on induction of labor. That is a null hypothesis. We know it is false. We need to reject it and then conclude that the mifepristone also helps to induce the labor and give a true positive finding. So we have correctly done. So null hypothesis is rejected when false. So it is power or true positive finding. So we can see the induction of the labor by the mifepristone. And null hypothesis is there is no effect of mifepristone on the induction of the labor. It is false. We should reject that false null hypothesis and conclude a true positive finding, which is power. And we are doing that here. You can see null hypothesis rejected when false. Power. Then the another related question, null hypothesis not rejected when true. So when the null hypothesis is true and it is still not rejected, what is the answer? It is the correct is the confidence. You can see null hypothesis is true. Okay, and we fail to reject, that is not reject. Then what we are concluding? We giving a true negative finding. For example, there is no difference in glucose between men and women. We know that the null hypothesis is true and we fail to reject it and conclude that there is no difference in glucose between men and women, and that is called as the true negative or confidence, which should be more than 95% minimum acceptable confidence. Then the another related question we'll see, null hypothesis is not rejected when it is false. That means null hypothesis is not rejected, we can say accepted when false. Okay, and this is nothing but the beta error, also called as the type 2 error. So here we see that is actually a type 2 error and not rejected when false. Okay, it is type 2 error. So null hypothesis is not rejected, fail to reject when false. Okay, it is false negative or type 2 error, also called as the beta error. Null hypothesis is not rejected when false. In other words, null hypothesis is accepted when false, beta error. Now the another related question is, which amongst the following condition is a type 1 error? Null hypothesis is rejected when false, null hypothesis is rejected when true, null hypothesis is not rejected when false, null hypothesis is not rejected when true, or none of the above. Okay, so null hypothesis is rejected when true is alpha error. Okay, null hypothesis is not rejected, accepted when false is beta error. Null hypothesis correctly rejected when false is power. Null hypothesis is not rejected when true is the confidence in our study. So power is the true positive, beta error is the false negative, and alpha error is the true false positive, and confidence is the true negative finding of our study. Okay, so we will see the type 1 error here. The mnemonic that we used, null hypothesis is rejected when true. That is, when true, we correctly, wrongly, actually rejecting the null hypothesis and saying that there is a difference. For example, there is a difference in creatinine between male and female. Actually, null hypothesis states there is no difference. Okay, or there is no difference in glucose between men and women. That is a null hypothesis. We know it is true. So we should conclude that there is no difference. But instead, we are rejecting the null hypothesis and concluding that there is a men have more glucose level compared to females. That is, we are giving the false positive, type 1 error, also called as alpha error. The minimum acceptable is less than 5% or less than 0.05. It is not similar to p-value. It is the minimum tolerable type 1 error or the false positive findings that we can tolerate, which we have to determine before finalizing the sample size of the study. Another related question is, which amongst the following is power of the study? So we already discussed, null hypothesis is rejected when false. This is the power. When it is false, we reject it and conclude the true positive finding. Minimum acceptable power should be more than 80%. Okay, so null hypothesis is false and we correctly reject it. It is the power. So in various ways, the question can be asked. The another question is on the forest plot. You can see here, a meta-analysis was carried out to review the effect of metformin in these PCOD patients. A subgroup analysis was also carried out on its effects in relation to BMI. The results are illustrated as below. Which of the following is true about the findings? So you can see, this is the forest plot. You can see there is a line of no effect here. Okay, which tells us about the null value of the effect estimate. Here the effect estimate is, let us say it is odds ratio. Okay, this is the odds ratio. And this is what is here. Odds ratio of 1 means null. The association is similar between those who are exposed and not exposed. So it is the odds ratio and the null value is 1. And the y axis is line of no effect. Always intersects the horizontal axis at the null value. Horizontal axis will give us the effect estimate in progression. Okay, so now these are the individual studies. This is the study 1 of 2010 study 1. We can see each square will indicate the one study. So there are 1, 2, 3 studies in the subgroup in whom the BMI was less than 30. There were 3 studies here, 1, 2, and 3 studies. And in BMI more than 30 group, we have 2 studies here. Okay, so the square box indicates individual RCT study or whatever study is considered. The width of the square box indicates the weightage given to the study. So this and this are given similar weightage. This is a small square, so is given less weightage because the type of the data that it considers, it may be having a low sample size or maybe underpowered or maybe with high bias. That's why less weightage is given. Okay. So there are certain horizontal lines here. This is the confidence interval of those the effect found out by the individual studies. Now, if the confidence interval of this horizontal lines of the individual studies touches the line of no effect, then the study is not significant. If we see here, this study is not significant. First study. The second study does not, horizontal line of the individual effect does not touch, it is significant. Third study is again not significant. Similarly, in the subgroups analysis 2, where BMI is more, this is this is a very high weightage is given for this study. And the confidence interval is also narrow, which means very reliable. The confidence interval does not touch the line of no effect, so it is a very significant study. Whereas the second study, very less weightage is given, very broad confidence interval, which is a very unreliable finding, and it touches the line of no effect, so it is not a significant finding in the second. Now we can see there is a diamond which is which will give us the overall odds, that is the overall effect compared taken when we calculate the all the odds and calculate the overall odds. So that will give the diamond. The sides of the diamond gives the confidence interval of the overall estimate. If it does not touches the line of no effect, then it is significant. And if it touches the line of no effect, it is not significant. In both subgroup, you can see it is not touching the line of no effect. So the overall effect is significant here. Okay. Now, the horizontal axis itself will tell us whether it favors the treatment or it does not favors the treatment. That is what favors what. Here the odds of improvement probably when we give metformin compared to the odds of improvement compared to clomiphene is given. When the odds are more, then that means the odds of developing good effect when we give metformin is more. When the odds are less, that means the odds of developing good effect when we give clomiphene, which is in the denominator, is more. So it favors clomiphene when the odds are less than 1. So it favors metformin when the odds are more than 1. So here in this group, in whom the patients with less than 30 kg, the odds, the overall estimate is favoring the metformin. So metformin is favored in those participants with BMI less than 30 kg per meter square, and the clomiphene is favored to give a good effect in participants with BMI which is more than 30 kg per meter square. Okay, so more than 30 kg means obese. In obese, clomiphene is favored, and in non-obese, this metformin is what is favored according to this forest plot analysis. So to summarize, the forest plot, metformin, the options are metformin is equally effective. No, metformin is less effective than clomiphene in obese group. Actually, metformin, is it less effective than clomiphene here? So actually, metformin is more effective in non-obese group. Okay, in non-obese group, it is more effective. That is what we can conclude. Metformin is more effective than clomiphene in obese group. Actually, it is more effective than clomiphene in non-obese group. Metformin is less effective than clomiphene in non-obese group. No, clomiphene is more effective than metformin in non-obese group. So what are the answers? So metformin is less effective than clomiphene in obese group. So we can see the metformin is less effective than clomiphene in obese group. Here the obese group is this one. The overall effect favors the clomiphene. That's why metformin is less effective than clomiphene in this group. Okay, so that is the explanation. The explanation, overall effect represented by diamond favors clomiphene and not metformin in obese group. So and whereas the overall effect represented by diamond favors metformin and not clomiphene in non-obese group. That is what we saw. So the forest plot details to summarize, it summarizes the meta-analysis. Vertical axis is a y-axis we can call, line of no effect, which is intersecting the horizontal axis at the null value. The null value for odds ratio, hazards ratio, and relative risk, etc. are 1. For the mean difference, it is 0. The horizontal axis, it represents the progress of the effect estimate. It could be any of the effect estimate we discussed till now. This individual square box represents the individual point estimate of individual study. Size of the square is the weight of the individual study. If there is a more sample size, less bias and less variation, and more power is implied, then more weightage is given to that particular study considered for meta-analysis. Horizontal lines, which will give the 95% confidence interval of the individual study estimate, and the diamond, which will give the overall study effect. The sides of the diamond gives the 95% confidence interval of the overall estimate. There is also a I-square value, which will give the heterogeneity index. It can range from 0 to 100. If it is more than 50, indicates studies are heterogeneous. If it is less than 40, the studies can be homogeneous with respect to the data that they are investigating. So that I-square value will be given somewhere here. So if we go back, we can see that the I-square value is given here. Here it is given I-square value. I-square value here. It is almost 0%. That means all the study considered are homogeneous with respect to each other in terms of the data that they are considering and the objective. Okay. So that is the I-square value, which will tell us about the heterogeneity. Now, if the horizontal line crosses or touches the line of no effect, individual study finding is not significant. If it does not cross, it is significant. If it is broader, the study finding is not reliable. If it is narrow, the study finding is reliable. Similar to if the edge of the diamond crosses the line of no effect, then it indicates overall effect is not significant. If it does not cross, then the overall effect is significant. Null value of mean difference is 0 and proportional is relative risk or odds ratio is 1, as I already discussed. So this is again summarizing individual studies and the confidence interval, overall study and the confidence interval, touching the line not significant, not touching the line significant. Here all are not significant. I-square, they are homogeneous study, and p-value is not very significant. So you can see the overall is not significant here. It is not favoring any experimental study design or effect of intervention. So in this topic, we discussed the study designs, when to choose them. We discussed the type of errors and how to describe them based on the null hypothesis. And then we also discussed the forest plot. So these are the three topics mainly covered in these 15 EMQs and 15 SBS. I hope this session was useful. Thank you.